Dave, it's 3 o'clock and we're at 60. Do you think we should go ahead?
Yes, I think it's 3 o'clock. Let's crack on.
All
Let's do
right.
it.
Good afternoon, everybody, and welcome to our second of our little webinar series for the Child Health Priorities Association. This afternoon, we are discussing a topic that I believe is a challenge nationwide, and that is the difficulty with children who get referred in largely by school teachers with learning difficulties and sometimes land up on the Department of Health doorstep where they require services more of Department of Education, and other times land up unable to access the help they need from the Department of Health. And so we have invited a panel today of some experts and then some healthcare practitioners who've tried to streamline these services in the corner of the country where they work and to share those lived experiences. So just to quickly tell you the lineup, we're going to start with Amina Ahmed from the Department of Basic Education. She is in KZN. We do have a bit of a KZN heavy panel today, but Amina has got years of experience with the department. I will share her full credentials in a minute, and will give us a feel for what they should have and what they don't have, and why we sometimes struggle to access help from the department. And then following that, we'll have Dr. Jill Douglas, a child psychologist, who will share insights from the psychology perspective. And then Jody and Mark will be sharing as pediatricians who work in the neurodevelopment and multidisciplinary space, and how they have tried to, they'll share with us some lessons from the field of what they've managed to do in their areas. So without further ado, I'm going to move to introduce Amina. And in so doing, I'm going to actually switch off my video. Let me see if I can change that. There you go. So Amina qualified as a speech and language and hearing therapist in 1995. In 2009, she obtained her postgrad certificate in education with specialization in ECD. In 2014, she obtained her honors in inclusive education. And in 2022, very recently, she did a postgrad certificate in project management. Amina worked initially in a special needs school for learners with severe intellectual disability. And then from 2002 already, she's been with the Department of Education, at that time in the Empangeni District Office, which is now renamed King Cetshwayo District, but she's still in that same space, but now with the title Education Therapist Specialist. And she basically supports the learners who are in special schools, as well as the learners at mainstream and full service schools. And she's heavily involved in the training of educators in various areas related to policy and strategy. So I think Amina is well versed in giving us some insight into what goes on at the Department of Education. Amina, I'm going to now mute myself, and I will share your slides, and you can let me know as you need me to advance.
Thank you so much, Dr. Mandy. I'm just going to put my video on. I don't know if anyone can see me. Can anyone see me? No? Oh, you're seeing the slides. Okay, let me switch the video off
No,
then.
we can see you. Hello. We're waving
Oh, okay.
at you.
Hi, I can't see you. Hi, everyone. Good afternoon, and thank you for having me on this webinar. I'll switch my camera off so that you can see the slides better. Thank you, Dr. Mandy, for that lovely introduction. And again, thank you for having me. So Dr. Mandy's basically covered what I do at the district office in King Cetshwayo. I'm going to give you an overview of what I'm going to be covering in this brief presentation today. So I will explain how our structures work in the KZN Department of Education in terms of supporting learners with barriers, both at provincial and district level. I know provinces are different, so bear with us. We may be very different from another province. Available specialist staff at education districts, which would impact this presentation today. Our referrals pathways for children that are in school and those that have either dropped out or never been to school before, which we put into a category called out of school youth. And then I will very briefly explain why the DBE policy on screening, identification, assessment, and support is so vital in this whole process of children with barriers to learning. So let's get into it. The KZN structures work like this. So at our provincial office, we have two directorates, which is not the ideal situation, but that's how the structure is at the present time. It may change when an organogram, a new one, comes into place. There is a directorate for special needs education services, and there's a directorate called inclusive education. So under special needs education services, you will find psychosocial services where educational psychologists are supposed to be housed. At the moment, you will see the stats under there. There is one educational psychologist at a provincial level, and that person is soon to leave us due to retirement. They have one school social worker, and these are what we call DCES level, which stands for Deputy Chief Education Specialist. In the hierarchy of post levels, it's equivalent to one level above a principal of a school. Then we've got career guidance services, which mainly works with children in high schools to guide them on pathways for career selections. And then we've got the HIV/AIDS life skills services, which deals with teenage pregnancy, substance abuse, those sort of programs. Yeah, there's a few other, but basically that's in a nutshell. And then we've got the Inclusive Education Directorate. At the moment, the staff there are very thin. They've got 3 DCESs that are there for specific programs. And those people are not permanent employed people. They have been seconded from schools. So they've got one DCES for the South African Sign Language program for our schools for the deaf. They've got one person for our special schools across the province. And they've got one person for our full service schools across the province. And they have no therapist at a provincial level in KZN, sad to say. So when we move to the next column, you will see district offices. So in a district office, there's just what we call a subdirectorate, and it's one subdirectorate called Special Needs Education Services. The Department of Education loves acronyms, so they call us SNES. There we've got psychosocial services where we should be having educational psychologists, intern psychologists, school social workers, school counselors, and sometimes a psychometrist. The career guidance is under that, the HIV/AIDS life skill is under that, and then we've got one that you haven't seen before, which is called Special Education Services. That's where I come in. So our ranking for the therapist at a district level is equivalent to a principal. So they call us education therapist specialists. The education therapists are the school-based therapists, and in KZN we have close to 170 school-based therapists across the 75 special schools, but that doesn't necessarily mean that each school has a therapist. We could have one with 8 and one with none. We have learner support educators, and we also have the learner support educators at district level, and we've got school nurses that are obviously at special school level. Okay, if we move on, I just want to give you an idea of what our organogram should look like in terms of posts and what we actually have. So KZN is demarcated into 12 education districts. They're listed there, I won't go through them. So King Cetshwayo is there, as you see. The organogram structure for a district allows for a psychologist at a DCES level and 3 psychologists under them. These psychologists would be educational psychology, 1 social worker, and this is what we have at KZN. In the whole of KZN, we've got 6 psychologists, 2 of which are interns, 1 psychometrist, and 8 social workers. Here too, the figures are not distributed per district. You might have 1 district with 2 psychologists and some with none. For example, King Cetshwayo has no educational psychologist. Then we've moved to the education therapist specialist on the other side, which is district-based therapists. The organogram would allow for 1 occupational therapist and 1 speech therapist in each district. So in total, we should have 12 OTs and 12 SLTs. KZN has 1 occupational therapist based at Pinetown District and 3 speech therapists based at me, King Cetshwayo, Umzinyathi, and Pinetown district. So we are sitting with the bulk of our districts with no education therapist specialists as well. A very bleak situation. Okay, let's move on. So basically, this is what we've tried to put in place because Department of Health is one of our biggest role players in terms of working with us to support learners who have barriers. And over the years, we know they've been inundated with our school-going age children. I think Dr. Jody is going to speak to that. So what we've done at our district, and it seems to be working, we have separated the learners for those that are in school and those that are not in school. So as I said earlier, the ones that are not in school would be those who have never attended school or those that have dropped out of schooling, because we do have that as well. Dropped out for more than 3 months, we would consider that an after-school child. So what we do there is if there is an available specialist at a district office, we would see the parent, we would see the child, we'd do a functional assessment or screening. And if there was an ed psych, they would do a psychology assessment. And then we would determine which special school the child needed to go to, either within the district, or if we don't have a school that caters for the child's needs, we would then make the necessary contact with the other district that particularly has that type of special school. Just for information, King Pretoria only has 6 special schools, and we're covering a very wide area. Our mainstream schools are just under 700 schools for King Pretoria, and we often find that some of our learners do need to be outplaced outside the district. And also our schools have got long waiting lists because of the large number of children and the smaller number of schools. So then the second one, learners who are enrolled at public mainstream schools. Here we're just following one policy, and that is the CS policy. For those of you who are not familiar with it, I'll just cover it in the next slide, but it stands for Screening, Identification, Assessment, and Support. It was gazetted in 2014, and then all districts started rollout in terms of training all mainstream educators on this policy, how it works, and what to do should they encounter a child with a barrier. The challenge we are having is that some are implementing it, some are not. There is a positive to it. Over the years, in the recent 3 years, I would say, we are getting quite a number of these referrals that are coming to us. And if a school has not used this process before, they are then being forced to use it because we are not in a position to travel out to a school to see a child at a time because of the short staff that we have, and also because there's a policy in place that needs to be followed. So what we would do is once a month, we would then gather all the referrals via the CS process, and we would have a case discussion. The panel should ideally be specialists within the district and any other relevant people. At the moment, King Pretoria has case discussions with 2 or 3 people because of our short staff. But once we do that, we will then take decisions on the child and what to do with the child and whether the child needs to move out of the mainstream school to a special school or remain. And if the child does remain in the mainstream school, we would then have to assist the school with completing an individual support plan for the child and guide them on how to continue support for the child. If we move to the next slide, it covers the Screening, Identification, Assessment, and Support Policy. This is the DBE policy, which means it's relevant for all provinces. Basically, I've just put a picture there so that one can recognize the policy. But on the other side, you will see we specifically ask for this package of documents when a school has a child that's experiencing a barrier. So they all come from the document. There's a learner profile. Basically, that gives us an information on background on the child, background on the family, as well as academic history, any kind of barrier that the child might have, whether the child is receiving any type of grant and what type of grant, because that also gives us an indication. Like, for example, there are many children sitting in mainstream schools that are already in receipt of a care dependency grant, which then automatically tells us somebody diagnosed this child with a disability somewhere along the line. Then we've got the Support Needs Assessment Form 1, which is usually completed by the class teacher. And if completed adequately and comprehensively, we would get a really good picture of this child. Your support needs assessment form 2 is usually completed by a committee within the school called a school-based support team, where they have a case discussion and they give us more information and they complete an individual support plan for the child. And then that needs to be attached. That's the next item. And then we've got a form DBE 120, which is the school requesting for support from us at district level. We ask for the latest academic report. Often we are finding in academic reports the marks that a child is getting is not in line with what we actually read on the SNA1 that the teacher writes, and that is causing a huge dilemma with us. Specialist reports, if any. Some children have already been to specialists, especially psychologists within the Department of Health, or an occupational therapist at some hospitals, and then that does give us a lot more background as well. And we ask for samples of classwork because one needs to actually see what this child's abilities are. And that gives us a really good picture, and we then take decisions from there. Yes, that's my brief presentation. Thank you.
Thank you. Thank you very much, Amina. That was a fantastic overview. I know you didn't have long, and I just want to remind those on the presentation that although you were giving us a picture of KZN Department of Health, I think that we would probably find across the provinces, with maybe a few exceptions, that it's a bit of a similar bleak picture in terms of what we need and what we actually have. And I think few of us in health actually understand how Department of Health Education has organized their structures. So that was really, really helpful. I'm going to move now to introduce our next speaker, Dr. Jill Douglas, who is sitting next to me. Jill initially trained as a nurse at UCT and did a master's in community pediatrics from WITS, and then worked in the child health space in the Eastern Cape. In 2000, Jill changed fields into clinical psychology and worked in child and adolescent mental health from 2014 to 2018 before moving to join us here in Northern KZN. She now heads the psychology services at Gwelazan Hospital, but also oversees the whole of Region 4 or Area 3 of KwaZulu-Natal, which is a very large catchment area. And her role is that of developing psychology services with a particular focus on child and adolescent mental health. So I'm going to switch over now to Jill's presentation, where we will hear a psychology perspective on this rather large challenge. Thank you, Jill. I don't know if you want to Jill's video or...
Good afternoon, everybody. Thank you for inviting me to share with you. And thanks to Amina. We work very closely with Amina, and thank you for that info. I think it was really helpful. So I just wanted to give you a little bit of a context. There's KZN in the red on the left, and this is our particular region. We serve 3 districts, 3 health districts. The green buttons are Queen Nandi and Gwelazan, which are the referral hospitals, and the yellow are the district hospitals within the King Dwyer district, which is the district that Amina has been referred to. We also service Zululand, which is the green district with the red dots. Those are the district hospitals there. And then farther north, we've got Umkhanyakude. The black pins represent the hospitals there. And the blue pins, you can see there, those are 3, those are CHCs. So just to say, we service probably about 3 million people within the district, and our distances are very far. You can see we sort of down south, as it were. Some of our hospitals are 4.5 hours drive away. So the distances are quite a challenge. So just to give you a little bit of a socioeconomic context, as I said, the distances are huge. It's predominantly very rural. Interesting, the figures are that 12 to 17 of the population have had no formal schooling, 31 to 36% have reached matric or completed high school, and 6 to 9% have had some form of tertiary education. This is the scary one. Approximately 40% of those 3 million people are under 15. There's a heavy dependency on social grants for survival. The 2 hospitals are based in the most developed economic hub, which is around Richards Bay and Mpangeni. And just to add a little cherry, there are many areas of natural beauty with our World Heritage Site of Isimangaliso along the coast. So ecotourism is an important part of the regional economy. So just to remind you, I don't think you probably need this, but let me do it anyway, that we normally think of children and their learning as, and their capabilities as fitting within the bell curve, the majority meeting expectations, a smaller group above expectations, and the few who really do superbly well, and then the group that we're most concerned with, those who fall below expectations or have serious underperformance. And that's normally how we, particularly in terms of our groupings, in terms of how we identify learners as psychologists, that's really the bell curve is what we use. I suspect that within our province, our bell curve leans not quite so much in that middle, towards that middle mean. I think we probably lean a little to the left, and I'll tell you why. I think this is a really helpful thing just to be thinking of, that there's a sort of a relatively recent concept of intersectionality, and it's really about understanding that there are many things that go to make up privilege, and they've drawn it almost as a wheel, that the closer to the hub you are, the more privileged you are, and the further out you are, the more marginalized you are. And I think what is true for many of our learners is that they are really on the outskirts. So you can see they look at citizenship, they look at skin color, they look at formal education, ability and disability, your sexuality, your neurodiversity, your mental health, your body size, your housing, your actual economic status, the language that you speak, and the gender that you are. So you can see that I think it's really important to think of learning and access to education with this kind of lens. And I think that particularly, I'm speaking from where we are working, that many of the children that we are working with are really on the margins of that wheel. Oh, sorry, we weren't supposed to do that. Let's see what's happening here. Andy? Yeah. Okay. We're just going to try and get to my slides on a different format, and I'll just speak to them. We just hit a techno glitch. There we go. So I think it's important when we're thinking about learning disabilities, that, there are a whole number of things that we're thinking about. We're thinking about things which affect the acquisition or organization, retention, and understanding of verbal and non-verbal information. And we're thinking about children who have impairments who related to perceiving, related to thinking, remembering, or learning. So that might be in terms of their language processing skills, their phonological processing, visuospatial processing, perceptual motor integration, their processing speed, how quickly they can do things, just the ordinary thing of memory and attention. We think of ADHD, and likewise executive functions, which is very much affected by ADHD. So those problems interfere with oral language, they interfere with reading, they can interfere with written language, mathematics, organization, and social skills, particularly if I'm thinking about our children with ASD. So you can see from this that there's a complex interaction between various learning processes, and you can see that for children with learning disabilities, the need for therapists who can address some of those issues is really crucial. Both the identification of what the actual problem is, not just a child who can't read or write, but actually really trying to find out why is this child not progressing at school. So both in terms of the identification of what is the issue, and then obviously to try and address it. I'm going to let Andy.
Apologies, I'm going to quickly try and get Jill's full slides.
Mandy, there have been a couple of questions in the chat already.
Sure.
I wonder if we can't direct those to Amina in the meantime.
You can, while I quickly try and open Jill's full one.
Yeah, you may even want to not screen share at the moment while we're looking at your desktop.
Sure.
So the one question is, where do learners with severe to profound intellectual disability and outreach team members fall into the district organogram? So that's the one question. Question if there are any audiology posts. And please explain why the process for learners in schools is so much more thorough than for those out of school, which is also an interesting question. So maybe we can just leave those questions floating for now and then come back and pick them up at the end.
Perfect. Dave, can you see the psychology layout
Yeah,
now?
we can see
Okay.
psychology. Yeah.
Perfect. Yeah. So I thought it would just be helpful to just give you a little bit of a breakdown in terms of how psychologists are trained. So one has a basic degree in psychology, which is usually a BA or BSoc Sci. You then go on to do an honors in psychology. You can either choose a purely academic stream, or you can choose to become a registered counselor through that honors program, or you can become a psychometrist. So those are at honors level. And then majority go on to do masters. There are 6 categories of registration, and they have different areas of focus. Clinical psychologists, which are the psychologists who are employed within the Department of Health. Counseling psychologists, which are generally psychologists who are in private practice mostly, and who deal with more family issues. They do some career guidance and deal with more sort of crises, sort of more normative crises, I suppose. Educational psychologists, which are very much the ones who should be in our educational setting. We then also have a new category called neuropsychological registration. So those are psychologists who have specialized in neuropsychology, which is really looking at where there's particular problems with brain trauma, with things like epilepsy, and we're looking at very detailed picture of what's actually going on in the brain. We then have a group of industrial psychologists who deal with psychology in the workplace, and then research psychologists who cover a whole multitude of sins. Okay, so just in terms of what resources do we have in terms of picking up kids with learning problems? Okay, so yourselves as a medical team, and likewise as many of our medical officers in our district hospitals, and also nursing staff, both at a PHC level. We get many referrals from them. For the rehab team, they're picking up kids who have difficulties from the get-go. Ourselves as clinical psychologists, we do have 3 registered counselors in our particular region, and within KZN, I think there are about 12 in total. School health services, we're trying to develop services with them, and then obviously our PHC services who pick up things at clinic level. So I think what I tried to do here with this slide was just to say, in terms of understanding some of the background in terms of a learning disorder, it's complicated. So sometimes it's genetic, sometimes because of substance use in pregnancy, in terms of something that happened in the birth and prematurity. So think about your high-risk clinic. Infection, okay, nutrition, just the old thing of stimulation and of kids not really having an early childhood education. Traumatic brain injury. Think about the number of children you see with MVAs. Think about your epileptic children. Think about the children with ADHD, with autism spectrum disorder, those kids who are in abusive situations and have experienced emotional trauma. Just the effect of what they believe about themselves and the attitudes of others. The huge load of parental expectation. I think we see that a lot in our particular context. Things like bullying, just things like depression, anxiety, the whole, almost epidemic of suicide that we're seeing in our adolescents, and obviously then substance abuse or misuse amongst our adolescent population of learners. So it's complicated. So we've had to think about what are our boundaries? How are we, for our plus minus 3 million people, just to give you an idea, we have 12 permanent clinical psychologists, 2 ComServe psychologists, and 3 registered counselors. So we really have to ask the question, who do we assess? And one of our challenges is that emotional and mental health issues often present with learning or behavioral difficulties, and often at school. So what we've been doing is that we only accept screen referrals. So that's either through the Department of Education, and Amina's very involved in that process. Our OTs, both at district level and at our hospitals, often are the ones doing the referrals, our medical team. What we try to do is do some screening before we see them. So we use the SNAPS-4. I'm not sure how many of you are familiar with it, but it's an open access ADHD questionnaire. We use the Strengths and Difficulties questionnaire. We have cognitive summary, which is a 1-page report, which we ask team members to fill in, just so that we have quite a lot of the background information is there. So we're screening for ADHD, particularly strengths and difficulties, looking for conduct and emotional difficulties, and then that's summarized in terms of background. We are looking a lot at access to grants. So a lot of the children who need care dependency grants to access specialized schooling, once they've been placed there, get sent to us to motivate for care dependency grants. And then we also are quite involved in the adult population with access to disability grant for those with disabilities who are over 18. And what we try to do is uncomplicated intellectual disability, if there is such a thing. We refer back through the CS system, which Amina has well described in the Department of Education. We have a standard letter for that. So I just wanted to finish with this, that in a way, Section 29 of the South African Constitution enshrines the right to a basic education. Recent research that reports that approximately 600,000 children are currently out of school. We have a history of a deeply unequal education system. And there's been a lot of debate around inclusive education versus specialized education, specialized schooling. I think we need both. I think we need to aim for education, we probably all agree with this, which is accessible, affordable, and without discrimination. It's interesting that the Western Cape Forum for Intellectual Disability took government to court, arguing that children with severe and profound disabilities had the right to education. They were previously placed under the Department of Social Development, and they won. And there has been some gains in that regard. And I sometimes wonder if we shouldn't go that sort of route. And I think for me, that we need to be developing those systems that Amina referred to, and that's what we need to be advocating for, that we need district-based support teams, social workers, educational psychologists, OT, speech therapists, remedial teachers, and curriculum experts to support teachers.
Thank you so much, Jill. I think that insight is so valuable. Firstly, just in understanding, I think few of us understand the ladder that one needs to climb to reach your psychological endpoint in terms of your training. And I think we forget that maybe that's why we sit with so many underfilled posts in both the DOE and in the Department of Health. But then also just remembering that complexity, which is why it's almost an impossible task to fully streamline our services. We have to work together with the 2 departments. Mark, I am going to stop sharing now so that you can load your talk. And while doing so, I will just introduce. So Mark Richards is joining us from the Western Cape. He is a neurodevelopmental pediatrician who works at Red Cross Hospital and has done since 2020 full-time. Prior to that, he was at New Somerset Hospital as a peds generalist. So thank you for joining us today, Mark. We look forward to hearing your lesson from the field.
Thanks, Mandy, and thank you to the other organizers. And it's a pleasure to be with you. Whenever I see those vast maps and services that are taking strain, I almost want to hide in a hole when I reflect on the experiences of the Western Cape. But without shining my own coin too much, I do want to hold it out with caveats. It's a dense urban area. Our distances are very large, but very sparsely populated compared to perhaps a more rural province like KZN. And our challenges are many. We have terrible urban and peri-urban social problems, and those affect learner education. So in some ways, the systems are perhaps working more efficiently, but the underbelly of the Western Cape is not a pretty place. So those are my little qualifiers as I come into this. So I'm going to start just by, I can just share my screen. David, am I good?
Not yet.
Not sharing.
Not sharing. Yep, now we can see it. And try that again.
Center mode.
Yep, that's it.
Okay.
Good to go.
So this is it's not perhaps a kind of deep dive into the sort of methodologies of assessment and how we would do it at Red Cross and some of the other hospitals, but it's more the story behind what I saw as a particular problem and how health and education interfaced. So primarily, it just seemed like there were years that had gone by when the two streams of education and health hadn't spent enough time with each other, and the language that we use is inevitably going to be quite different, but also the degree of commonality and how we interface with one another wasn't there. I have major reservations about the CS document, particularly as it relates to how health workers interact with education. It uses language that we're not particularly familiar with. And so whenever you meet these kind of points of high resistance, people start doing things differently. And that's what I'd seen over years. And so I started having meetings with the education teams, both assessment teams and also the sort of administrative leads in the education department. Ours is quite a complex learning support system. We have sensory schools, what I would call hearing and vision, and then there's children on the spectrum, the dedicated spectrum, and intellect and physical, and they are quite opaque. And when it was a particularly kind of paper-based system, it was a very, very difficult system to negotiate. And I, working in the field, didn't really know how things worked. And I was also a bit worried that there was the kind of, to the race, go the quick. And people who were able to drive to schools and drop off forms and understood how to work a system were at an advantage. And our ability to reference the referring system as from the health side was opaque. And so there needed to be a sense of an improved governance and also legitimacy in what we were doing, and that we could all look at each other in the face and agree that there was fairness in it. So and then the uniformity in assessment, how we understood certain fields, and I think within hearing and vision there was a sort of uniformity about it, but with an intellectual disability and autism, there was very little uniformity. And I think what was happening is that there was granularized sort of expertise at the local level, and that was quite different to where a child might be being assessed. And it resulted in a cottage industry of different systems, and it was a mess, at least from the health side. And then the bugbear of paper-based referrals, which over the years, as we all know, what happens to a photocopy, it started, most of the lettering was at 30 degrees, sliding off the page, and the language wasn't correct, and that was given to a parent to go to the local school, and who knows what would happen with that. So we needed to move, and I think perhaps the overarching experience for me trying to manage a precious resource within a tertiary service, and also those within perhaps larger regional hospitals, was that hundreds and hundreds of children were coming to our tertiary services with a request from everyone, please find a school. and I got tired of that, and partly sort of self-preservation, self-protection mode, but also just aware that if there's such a tiny pinch point in the system, there has to be a problem, and that needed to be devolved. That process needed to be devolved to people who had absolutely sufficient expertise to understand children's developmental support needs, and a health system which also had the capacity to understand those people speaking. So we got together and we chatted and we had meetings, and we started defining our impairments and how we would understand those in an improved way, not a perfect way, and it's still, I'll get to that, some of the problems. We moved the referral system over to Office 365, and I'm pretty sure that most of you in government will probably be using a gov.za platform, which is going to have integration into 365. It's going to probably be expensive, but for that's probably costs that are already being paid. And there's a whole world of organizational capacity that sits in the sort of Microsoft domain. And I do have a bit of a techie inclination, but really the interface for most of us needn't be that complicated. And I'd be very happy just for you to sculpt the stuff that I've got, and I'll put a link there. But it looks like for those of you who are interacting, it's just a Microsoft form, and I'll get to show you the interface there, what it looks like. Yeah, so what would then happen is that the health worker completes the assessment using simple language with text boxes. If there's greater refinement that you have in your assessments, that you can stick all as much as you want within the text boxes. That is entered. If you put all the correct email addresses, you'll get a copy. And then what happens, all that information goes to a central coordinator who then moves that information to a district office where a child lives. And then onto the particular, depending on the child's impairment or impairments, will then go to the relevant assessment team either at the school or within the district office. So that complexity of understanding the education system was moved away from health into education. And it's able to be completed by anyone who's registered with the Health Professions Council. By necessity, I've needed to try and keep those assessments as accurate as possible. And so I'm very well aware of the huge caseload that nurses are managing, but the form does require one to have a registration, a health professions registration. So that's the interface that you have. I'm sure all of you have completed forms of one sort, whether it's to do a park run or fill your taxes in, but that's what it looks like. And there are different branch points. If you're saying you're not registered, then the form ends. But if you say yes, then the form continues. Those are the main domains of concern. They look like CS policy sort of items. And I've tried to take the best of what I think is in CS and to use it here. And that's a nice clean, a relatively clean impairment domain hearing, and with designated categories that health workers within the field would understand. And it churns out an email which gets sent to you, the app or the kind of form filler, and then potentially to a child, but also this would then go to what you see at the top. There's Laviva Adams, who's a person within the provincial office who then moves that form along to the right people with all the information on the back of it. And now we have a database, and that is shared between education and health. So I can go back to it, or someone can go back to it. And I try not to answer too many of these emails, but someone can say, did this go? Did it happen? Is the child in the database? And you can say yes or no. The child is there with all their details. A critical requirement for people to have obviously contact details. And so that was the essential, is that when you are completing this, that you do have the ability to, well, at least you ask people, please, will you give me accurate numbers? Give me as many telephone numbers as you can so that you don't fall off just because your phone got stolen. So what's still not ideal and this is an ongoing process, is how we understand autism and intellectual disability. Now, within the scope of an inclusive education so many children who are in these categories should be within mainstream schools. We don't have that capacity. There's still a legacy of autism finding its way into autism schools, and how you understand an autistic child who's completely competent with finding their way down the right-hand column of YouTube, but is not able to hold a conversation, and how those children fit into schools and what you would offer an education department or a particular school, the metrics of what constitutes autism or intellectual disability is a very complicated task. And something that I'd love to see more work on. But I will, there's a link. It's obviously, I don't think it's clickable for you, but I will, if there's interest, I'm happy to post that. It's a little practice form. And for those of you who are interested and we see how this discussion goes, I'm very happy to share with you some of the sort of technical elements of it and see how we can reproduce it. And my happy land, I think, I must say, is for the whole of South Africa to sort of come on a platform like this and use something that we can all share together, certainly with the testing modalities. But I do realize that the educational ecosystem that sits on my side is quite different to yours. So there may be some limitations there. But that's all I've got to say. Thanks very much.
Thank you so much, Mark. I think we're all sitting in awe of not only the wonderfully streamlined paperwork, but also the fact that you have someone to send it to on the other side. And I think that's exactly what you've recognized, is it works fantastically where you do have people. And we're so blessed to have Amina, who holds the whole sort of department on her shoulders in this area. And you've got someone per district who you can engage with. But I think these are important conversations for anyone wanting to start a streamlined system in the area. So possibly you'd be able to share that link in the chat for us. I'm going to introduce our last speaker now, Jody Wiles, who works with us. Jody is a pediatrician. She's the head of clinical unit for the CP Center of Excellence, actually, here at Queen Nandi Hospital. But Jody has a background as well in working with neurodevelopmental peds and palliative care. And Jody is sort of our expert in pulling teams together and having tea with multiple different disciplines to make things work. So Jody's going to share a very short lesson from the field as to how she partnered with Amina to try and streamline in our area. Thanks, Jody.
Thank you very much, Mandy, and good afternoon to everybody. And also thank you so much to our previous speakers, especially my colleagues here in KZN, who I think have really painted the picture of where we are at the moment in terms of children with learning difficulties and accessing their assessments and their schooling. I just want to sort of frame it as well in terms of the medical and our hospital that I work in, Queen Nandi Regional Hospital. You saw Jill's slides earlier in terms of the geography, and essentially Queen Nandi is a mother and child hospital. So we see children under 13, and we are the referral hospital for that area 3, region 4. So children from throughout that area come to us, and then of course we're also a district hospital. So in our very own district, we get referrals from our district level. So that's in terms of just the medical side. And so when I refer to the POPD later on, it really is quite busy, and we have, I would say, about 2 dedicated clinics from a medical side to neurodevelopment, actually 3, sorry, if you include cerebral palsy. So we have a very busy neurodevelopmental service, and fortunately lots of doctors who are interested in it. So that's where I am at the moment. So today I just want to share with you a brief snapshot of how we collaborate with Department of Education. So just as a background, I hope everyone can see the screen. We had an existing understanding with Department of Education because of what you've heard, because of the lack of psychologists within the department, that we would provide psychology services, particularly for children who have medical and underlying conditions. So that was an existing MOU that was in place so that children who do come to our POPD can be have a comprehensive assessment and then be redirected to a psychologist or OT or any other specialist or a therapist that we thought they needed. the problem that we were sitting with, there were two main problems. Firstly is that the problem of children at mainstream schools with learning difficulties not being able to access assessments. And I think some of the things, just brainstorming, that I thought of that led to this is that parents and schools were unaware of the SIRES policy. And of course, as you've heard, essentially there's one therapist who they could refer to for the SIRES policy. And so the way it impacted us is that a large number of children were self-referred to POPD, which obviously puts an additional barrier on the work of the doctors there, and requiring a lot of coordination by the attending medical officer and the rehab departments. And this wasn't part of our MOU. The second problem is that of children who required care dependency grants and required assessments for those grants. And many of these children were already in special schools, or we have one or two main special schools in our district. And there was no educational psychologist in Department of Education to do this assessment. And of course, that would lead to inconsistent access for children, for accessing care dependency grants, and long waiting times for these children. So those were our problems that we, excuse me? Okay. So what we did, we also met and we didn't have tea together, but we had a meeting. And this was with Department of Education representatives. Sorry, there's a mistake there, but essentially Department of Education, who was Amina and one of the principals from our special school, and then our OT psychology department and myself from the medical side. We did not have DSD in that meeting. And essentially what came out of that meeting is just communication and being able to streamline the referral systems for these particular groups of children. And so we were able to create a clear guideline for our medical staff, which was distributed. And Amina went back to the Department of Education and communicated with the school health staff and the school principals. And out of that, we also developed a letter that we could give to the schools. And I'll just briefly, I might come back to the slide, but just to show you, this is essentially how we are functioning at the moment. So a school-age child with learning difficulty presents at POPD. Our first question is to ask whether they're attending in a mainstream school, and usually these are self-referrals. And then we have a letter that we give to them that they can give back to the school principal, reminding them about our SIRES process. And then, of course, that's all initiated. If after having been assessed at the Department of Education therapist, there are still needs and particular assessments that are needed that the Department of Education don't have, for example, audiologists or psychologists, they're then redirected back to Queen Nandi for those particular therapists and assessments. And so that's the middle stream, those children who have been assessed and needed, or those already in a special needs school, and usually referred from that school, will be then directly sent for assessment at Queen Nandi, and can bypass the POPD. And then, of course, as I spoke about in the beginning, those children with an underlying medical condition or not attending school will have their comprehensive assessment via the usual route in POPD. So that's where we are at the moment. Just also to say, through this process, we are, in terms of the second problem, there is very good communication between Amina and our psychology department here, in terms of those children at special schools needing assessments. She creates a list and she sends it to our psychologist, who then gives her dates and then red flags those children once they've already been seen. So that's what's happening in terms of the care dependency grant. So just to end off, yes, how do we maintain momentum? How do we improve? I think I'm in awe of the people in this room here who are actually advocating and working incredibly above and beyond for children in this area. Amina, Jill, and my other colleagues. And it's just it is quite a privilege to be able to just phone them. They're almost on call for us if we have issues in our PAPD. So I think this process just opened that communication and showed us that we can work and collaborate together. And obviously, as Jill pointed out, we are advocates for this area, which we can see is a huge need. Some hope for the future. I'm hoping there's more staff. We can't lose hope, but we are doing things slowly, having small wins in terms of getting more training. Also for general staff, for example, we have quite a cohort who are accessing Griffiths training, and that's through a discovery grant that psychology has organized or won. And Amina also tells me that in terms of our SASA situation, there will be training for all healthcare professionals to be able to do functional assessments so that children with disability can access their care dependency grants. So there is some hope, and we just need to keep on keeping on. Thank you.
Thank you so much, Jodie. So I'm going to start with some of the questions in the Q&A. Dave, you read a few out while we had our little technical glitch. We needed our tech-savvy Mark at that point. Amina has had a chance to prepare some. So I'm going to ask Amina if you can unmute, and then I know you've had a chance to prepare some of your answers now, so maybe you can tell me which question you want to answer and just read it out and then tell us what you think. I don't think we'll be able to get through all. There's an overwhelming sense of desperation on the Q&A, but Amina, if you want to go ahead. Thank you.
Thanks, Dr. Mandy. I will try and get through all those that are DOE as far as possible. Not sure if the answers are going to be adequate, but let's try. So the first one, I want to apologize. I didn't deliberately leave out the transversal team that is there for children with learners with severe to profound intellectual disabilities. So that's a new program that has been initiated at DBE level. So all provinces have these teams. At the moment, KZN has got 6 teams. They are working across 2 districts at a time. So in our case, we've got a team that operates between Mkhanyakude and KC. The teams comprise of a team of therapists, speech therapist, physio and an OT, 1 educational psychologist, and what they call a general senior education specialist. However, these teams are specifically for that category of children. So in the initial stages of when they were appointed at DOE in KZN, they were reporting directly to our provincial office. Subsequent in the last year, I would say they've been asked to report to their host district, and in our case, it's Mkhanyakude, not KC. But their category of learner is just for the profound, severe to profound. So it's the children in the care centers that were under Department of Social Development in the past, and still are many care centers. They are now training caregivers and care center managers on a learning program for these learners. And they also work with, in KZN, there are 34 designated special schools that are supposed to cater for these learners, so they would only service those schools. When it comes to children with general learning barriers, they don't get involved in that. We are not even allowed to take them out to use them for any kind of psych assessment, even though they do have a psychologist. And the reason for that is because this is a grant-funded program. And they are part and parcel of DOE now, but when they started, they were on contract posts. So I'm not sure if that answers that question. I could say a lot more about that, but I think that's enough for now. The second one, any audiologist posts, not at district level. Education districts at KZN does not have provision for audio posts. There was a provision for a speech, language, and hearing therapist. So if they did advertise new posts now, it would not necessarily be the hearing, it could just be a speech therapist. The audio posts are supposed to be at schools for the deaf. Not all of them have them, but that's where they are located. The next question for me, the next one was, thanks, Dave. Okay. The process for learners in school is, why is the process for learners in school so much more thorough than those for out of school? Okay. Maybe I didn't cover it enough, but the ones for out of school are also thorough. We meet with the parent, we take an intake interview, we do a very thorough screening assessment, and we also get background information from any other relevant source. So I wouldn't say it's not as thorough, but it would be a lot more intense because we're meeting with the parent, we're seeing the child, we're working with the child to take a decision. Yeah, so when it comes to a child that's not in a school, it's very difficult to ask for paperwork from anywhere because the CIAS is particularly geared for a child who's been in the schooling system. Where do we refer children of 14 plus years for an IQ assessment? Okay, that one, I'm not sure how to answer that one. Maybe someone else wants to take that one.
I think I'm going to carry on with the ones that are yours.
Okay, the next one by Michaela. That's a very sad thing, Michaela, that you are needing to be inundated with CIAS documents. What I want to say there is, yes, there may be some districts that have got no specialists, but the district staff complement at special education and psychosocial within the SNARES directorate that I covered, subdirectorate, does have people which they call senior education specialists. And those people are supposed to also facilitate the receival of CIAS referrals. So you may not have a specialist, but there should be department officials within the SNARES section that should be taking this on, because CIAS is a DBE form, it's not a Department of Health form. And rightfully so, as Mark said in his presentation, that is not something we are expecting Department of Health to understand. We understand why it was put in place and what was its purpose. So I would think you need to reach out to your other staff members, even if they're not specialists within the district. That is a challenge. Some are not wanting to move forward and engage with other departments, but we need to try. The one about therapist posts, yes, that is true. We are having a problem with that. The support, okay. Yes, the issue of classification of MID and SID. I do want to say one thing. As therapists, we are not allowed to diagnose any one of these, but our CIAS policy is talking about levels of support. So we're looking at whether a child requires high level support, moderate levels of support, or low levels of support, and that would determine which type of school we would put the child. So the child that is requiring high levels of support would go into a special school, and some of them into SID schools, and the MID would probably go into full service school or a special school that offers an MID program, like a remedial school or a pre-vocational facility where they teach skills. So that's how we work. We don't always get a diagnosis, but we look at levels of support. So basically unpacking that, we're looking at the age of the child, the grade that the child should be at, and what is the gap between the two. Like, for example, a 12-year-old that is unable to read and write. Okay, let me go into the next question. How does CIAS support children, and how can they equip local schools to implement inclusion? Yes, there are many children with disabilities that are not accessing special schools because the schools are full, and so they wait on waiting lists to go into school. So what some of our schools are doing, our special schools in KC, is they are running parent support groups for these children on waiting lists to equip them with skills. But if a child is sitting in a mainstream school and is waiting to go into a special school, the individual support plan is what we work with the teacher with. Our learner support educators, those districts that have them, work directly with the school, the class teacher, to develop that, to refine it, because it should be in place. And it's curriculum differentiation. So support is through the curriculum, and educators are supposed to know their curriculum they're teaching these children. And so we basically equip them with skills on how to differentiate the curriculum. And we also run workshops on inclusion, strategies for support. We started with a series of that in KZN just a few months ago, and we're plodding along our vast district. I know I'm not answering every question fully, but I'm trying to get through all of them. Does the Department of Education provide any assistance for children in private schools? Well, private schools are not governed by education policies, but we will not turn a child who has been referred to us by a private school. It's just that if the child requires a public special school, we will assist and treat the child as an after-school learner. Reason being, because we will not get the CS documents from a private school. They have not been workshopped on it and they don't implement our policies. But we would then retrieve other documentation that might be relevant to the child from the private school if required. So we do work with private schools in that capacity, but not directly in terms of trainings and workshops and that sort of thing. Okay, the part about inclusive education and white paper, the white paper being a failure. Okay, so children means that even those children who require the support as outlined in CS cannot get the support in schools that they are already attending. Okay, I wouldn't say that the white paper 6 has been a total failure, but we are slow in getting it to where it should be. But I think CS is there. The issue being that at school level, they are also having many learners in a class, and that causes a problem to implement CS. They also have other conflicting things like curriculum coverage. So what we have done here in KC is where we are finding schools are lacking with implementing CS appropriately, we are getting to the school to retrain them. So I think we have come some way. It's just that we're not completely there yet. I wouldn't totally disagree with you there. Shanaz is just making a comment, and I like your comment. Yes, well done. I agree with you. Glennis is talking about having cups of tea together, and that's exactly what we. Yes, are we out of time?
No, almost. We've got time for maybe 2 more, and we can continue this conversation sort of on email because we're going to share the webinar. But can you read out that comment that you said you like very much? Because not everybody can see the Q&A.
Okay, it says the majority of educational difficulties young people have may not need a full psych assessment, which is expensive, timely, and not always context specific. It would be helpful to have a basic educational screening that can be picked up and fixed through easy intervention. I also think as a psychologist who has worked in public health, these skills and roles can be undertaken by trained teachers, counselors, and occupational therapists, not only psychologists, as most psychologists have not been trained on how to work with the public health population, which results in massive misdiagnosis. I think the point there was basically that we need to spread it across. Yeah, okay, so yeah, the DOE, DOH engagements, I totally agree, completely necessary. We had that problem in KZN, we've solved it because we talk to each other now. Well, here in KC, I would say, let me not go across the province. The reason why we can't do more, ladies and gentlemen, I would just like to give that background quickly before we end. It's not that DOE doesn't want to employ these people. The issue we are having in KZN, I don't know if this is unique to us and other provinces are good, is the issue of cost-cutting measures. They're not employing more people because there just isn't funding for it. That is the bottom line. And as frustrating as that is, and I know the effects it has on the children out there, our hands are tied with that one, although we do moan and groan. Okay. There was someone who is asking about what they can do with a 6-year-old visually impaired child. I would think we need to know which district this child is at, and then we can advise you on where to go. If it is KZN, if it's in...
I think we can answer that in the chat, those specifics. Can I just ask you right at the bottom, if you scroll down, there's a question about the early childhood development population that have moved from under DSD to under Department of Basic Education.
Oh, that's okay. I'm seeing that now.
Which is quite helpful, I think, for everyone. And then that can be our last one that we answer live, if that's okay.
Okay, perfect. So ECD has moved into Department of Education as sometime last year. In each of our circuit offices, where the district is broken up into circuits, they have a designated person there who's usually a social worker. We work with them, and just recently this year, we started training our ECD practitioners on pre-literacy, pre-numeracy skills, on the CS, on children that experience barriers, what to do, referral processes, etc. So yes, they are part of ECD, of basic education, and we have started to unfold that program. And of course, from a curriculum perspective, our GET section, which is responsible for children in primary schools and ECD facilities, would be training them from that perspective in terms of curriculum. So it's unfolding. It's just that it just happened like now, recently. So yes.
Thank you. Thank you so much, Amina. It's always a race to the end with these webinars to try and get through all the Q&A. And I think these conversations, as somebody correctly put, are so valuable, and we can't lose a single word of the discussion, as our colleague mentioned. So just to note that the link for the recording of this whole session will be shared via the Child Health Priorities email chain. And I just want to thank again our wonderful speakers today who have highlighted a massive problem. And I think we knew it was there. Maybe we know now that it's even deeper than we thought. But also some hope and some positive take-home messages of how we can overcome the problem. And then I also just wanted to alert you that although these two first webinars that we hosted were not CPD accredited, our conference in December is looking strong and is accredited. So please refer to your email links for registration for that conference. And we just want to thank you very much for joining today. Thanks, Amina, Mark, Jill, and